We present one of the most challenging cases, cataract surgery in eyes that have undergone a prior radial keratotomy. Patients who had undergone the RK surgery in 80s and 90s are now developing a visually significant cataract. The main challenges here pertain to the perioperative planning, surgical execution, and the refractive expectations. A 66-year-old gentleman who had undergone a 16-cut RK presented to us with cataract in his right eye. The 16 radial lines are very deep at 90% depth. Usually we use the Pentacam 4-map refractive scan for the steep and the flat K values. However, the Pentacam Holiday EKR report that gives us the equivalent K readings in the different zones from 1 to 7 mm is more accurate. EKR 65 mean can be used in the post-refractive surgery calculator. The other option is to use the total corneal power coupled with the Holiday 2 formula. LensStar and the IOL master report giving us the required biometry data and also showing us the A constant for the different IOL formulae. To calculate the IOL power in post-refractive surgery patients, we can use the ARCRS online calculator, which is freely available. The required patient details are filled up and then we move to the pre-procedure records if they are available to us. However, it is not mandatory. Instead of the Atlas ring values, we can use the Pentacam EKR zonal values for the 1 to 4 mm rings. The appropriate biometry data is then filled up. Important point to note is that the target refraction should be kept at -1 or -2 depending on the cuts on the cornea. Here we have used -2 as it is a 16-cut RK and we don't want a hyperopic surprise. The calculator will then give us the IOL power for all the available formulae with the given data. Average value should then be used for the best results. Scleral tunnel incisions are typically preferred for wound construction when we have more than 8 cuts. A clear corneal incision can be made between the RK cuts. However, the incisions close to the RK or too central are at a higher risk of enhancing the irregular astigmatism and affecting the structural integrity if they cross the RK cut. We anesthetize the incision site with subconjunctival injection of 2% lignocaine. A small fornix-based conjunctival flap is created. A 3 mm triplanar sclerocorneal tunnel is made while taking care to avoid entering to the anterior chamber across any radial incision. Viscoelastic is injected as and when required. 2 side ports are made and we specifically choose the clear axis in between the radial cuts. A continuous curvilinear capsular excess is performed. Dentin but thorough multi-quadrant hydrodissection is completed. Phacoemulsification is performed under lower parameters and a low bottle height in order to maintain the integrity of the cornea. Here we have used the direct vertical chop flower petal technique for optimal results. Bimanual irrigation and aspiration is completed. A single piece foldable IOL is injected to the sclerocorneal tunnel. Wounds are hydrated and the conjunctiva is cauterized. We had a very satisfied patient on the post-operative day 1. We usually advise temporary glasses for patients at the 1-month follow-up and repeat the final refraction at 3 months as the wound stability is achieved. Thank you.